Thanks, Irv, and I want to thank Chris and Kristen for organizing the meeting, and all of the speakers. I think the speakers today have been absolutely wonderful. I'm only sorry we don't have more residents here, but the residents are in the clinics and the OR today. But the meeting has really been outstanding. My job today is to talk on epithelial basement membrane corneal dystrophy. And in 10 minutes, you can't really talk about recurrent erosions as well, but I'm going to stick that in a little bit. No interests in what's going on as far as no drug companies. Epithelial basement membrane dystrophy really is something that started in my ophthalmic lifetime because David Kogan described microcystic dystrophy in 1964. David Kogan was one of the great ophthalmologists of my time. He has several diseases named after him: Kogan's microcystic dystrophy, Kogan's non-syphilitic interstitial keratitis. He also wrote a book on the extraocular muscles and the innervation of the extraocular muscles, and he was a great pathologist at Massachusetts Eye and Ear Infirmary. But he didn't see the map-like changes surrounding his microcysts, which were described by Gary in 1965. Vogt described fingerprint lines in the cornea in 1930, and DeVoe rediscovered them in the 50s. And then Tony Braun talked about blebs of the cornea. But there are many, many different things in the cornea that you could say is related to epithelial basement membrane changes, not dystrophies. John Trobe, a resident at Wills and now a neuro-ophthalmologist in Michigan, and I put together a number of these different things and labeled it map.fingerprint dystrophy when John was a resident here in 1972. These microcysts that you see here are tiny little dots and little larger irregular areas in the cornea that Kogan described with Kuwabara, Kinoshita, back in 1964. Surprisingly, these dots were surrounded by very, very faint epithelial and subepithelial lines that you see here. These were really not subepithelial, but they were at the basal epithelial layer. Most of the patients that you see with epithelial basement membrane dystrophy have these lines and don't have the microcysts. The microcysts of Kogan are something that is seldom, not rarely seen, but seldom seen. The problem with these changes in the cornea are when they're present in the visual axis, they cause a very slight elevation to the epithelium, causing an irregular astigmatism. So if you look here, the light coming from the left to the right, there's a shadow along the right side here, which causes a slight irregularity in the ocular surface and blurred vision. Back in 1974, Merlin Rodriguez, when she was the pathologist here, and I, and at the same time, David Kogan, in another publication in the same archives issue, showed that these linear changes surrounding the microcysts were actually caused by a change in the corneal epithelium. This is a very copied picture, but this came from our original article in the archives with Merlin Rodriguez. I think Zimmerman was also on this article. But you see the basement membrane here underlying the basal epithelial layer, and it seems to be going up into the epithelium. Well, if you bring this out, this is a sheet of basement membrane, and it prevents the epithelial cells from slowly rising and then desquamating from the corneal surface. They accumulate beneath the basement membrane and may form very large microcysts or very small microcysts. And this is the etiology of Kogan's microcysts in epithelial basement membrane dystrophy. Fingerprint lines that you see here are really ridges or rows of thickened basement membrane. Another slide, which is often duplicated from our paper, shows the very thick basement membrane in furrows or rows. And if you see them coming out at you, these are actually the fingerprint lines that you see in the cornea. Well, Jay Kratchmer, when he was a fellow in 1974, and I looked at about 5 or 6 families where we saw 2 or 3 generations of epithelial basement membrane changes in the cornea. And we call this a dystrophy because we found this in multiple families. Werblin, Hurst, and Stark at Hopkins looked at a bunch of patients in 1981 and said, well, we see this in 50% of the patients. However, very carefully looking at about 250 patients, normal patients, who came in either with patients that we saw or people who had no complaints, were looked at by George Waring, Jay Kratchmer, and I in our 3 institutions, and we found the incidence of basement membrane changes in only 5% of the patients. Bootbull, Graham, and Black in 2006 found there were mutations in patients with epithelial basement membrane changes, and according to the IC3D classification of corneal dystrophies, this is a C1 classification dystrophy. This was published in 2008. So we feel that epithelial basement membrane dystrophy is a dystrophic change in the cornea. There are 2 problems with epithelial basement membrane corneal dystrophy. 1, it causes blurred vision, which you saw if the changes are in the visual axis, causing that irregular, slight irregular astigmatism. And 2, it causes corneal erosions. Most of you know about corneal erosions and recurrent erosions. We don't know why the basement membrane does what it does in those pathology pictures, and we don't know why the epithelium loosens. But in a significant percentage of patients with epithelial basement membrane dystrophy, corneal erosions are the symptomatic changes. How do we treat corneal erosions in epithelial basement membrane dystrophy? Now, this is different than traumatic recurrent corneal erosion. Traumatic recurrent corneal erosion occurs usually in the lower half of the cornea and is treated in a somewhat different way than the erosions in epithelial basement membrane dystrophy. We treat the traumatic erosions in the lower half of the cornea with anterior stromal puncture. Generally, I do, or I did. But the erosions in epithelial basement membrane dystrophy are treated medically at first with artificial tears, preservatives, hypertonic sodium chloride, ointments, gels at nighttime. Some people like to use oral doxycycline. I stay away from the anti-inflammatory steroids or cyclosporin, but some people use patching, partial lid closure. If the erosions are multiple and recurrent, temporary tarsorrhaphy might be done. A bandaged soft contact lens has been talked about and does work. However, I do not like to use it over extended periods of time because of the threat of bacterial infection. Autologous serum has been used, and fibronectin drops by Nishida in Japan have been also used. Once medical treatment fails, then surgical debridement of the epithelial basement membrane dystrophy in the visual axis is the treatment of choice. And this can be done at the slit lamp with topical anesthesia and a Barricare speculum. Usually a sterile Wexel sponge is all you need to remove the loose epithelium. And then the way I treated these patients was with diamond burr polishing of Bowman's membrane. Just doing the debridement alone, you leave some complexes behind that may lead to further changes in the corneal epithelium and further recurrences. But taking a 5 millimeter diamond burr or a flat burr and then just polishing the debrided epithelium in the center of the cornea for 10 to 15 seconds works very well. Others have used chemical delamination, alcohol, and other things, and some have used PTK, a phototherapeutic keratectomy, for treating this. PTK works very well. It will remove all of the complexes. Of course, you can go into the superficial region of Bowman's membrane. However, this is far more expensive and more difficult to do unless you have a laser in your office than just doing epithelial debridement, not debridement, and mechanical polishing with diamond burr. The advantages of diamond burr polishing for recurrent erosion in EBC-MD is it's an office procedure, relatively inexpensive, little surgical skill, actually no surgical skill is required, small investment in equipment, No permanent scarring, unlike anterior stromal puncture, which may give a very slight haze for a few months. The recurrence rate is quite low, and there's minimal, if any, refractive shift. Sometimes retreatment is necessary. I would guess when I was doing it, maybe 10 or 15% of the time you'd have to retreat along the edge if you didn't go out far enough. But that was not a big deal because you could repeat it. Now, this was a slide I put together some years ago to show Wills Eye Hospital's treatment, 27 patients, Kellogg, 54 patients, Hong Kong, 25 patients, and Tony Aldave at UCLA, 56 patients in his series. The site in the office or minor operating suite. The prep was simple, none to a mild drape. Debridement extent, we did just the loose epithelium. We would take the Wexel sponge and go back until you just could not easily remove epithelium. Kellogg did it to 1 millimeter of the limbus. Hong Kong did it the way we did it, and Tony Aldave did it the way they did it at Kellogg. Most people use the Wexel sponge to do this, and we and Hong Kong and UCLA used the diamond burr. Kellogg didn't specify what they did. The burr time varied from 10 seconds to 30 seconds. I think 10 to 15 seconds is all you needed. You didn't have to press hard into the cornea. You just rotated that diamond burr around the central area that had been debrided. Bandage soft contact lens just for a day or 2 or 3 to allow for reepithelialization and comfort. And steroids or no steroids was certainly not a big deal. We used steroids about half the time, and NSAIDs at Kellogg, none at Hong Kong, and steroid with taper at UCLA. This is the flat-headed diamond burr, which is easily purchased, or a 5, not the 3 millimeter, the 5 millimeter diamond burr. It's nice that when you answered the question in the beginning, I think 71% said they would use debridement. We've talked about that for many years, and we really think that this with the diamond burr is quite helpful. So, for dystrophic recurrent erosion in the visual axis, medical therapy first, and then debridement with a diamond burr, or PTK if you have one easily in your office, and usually no anterior stromal puncture because that's reserved for recurrent erosion from trauma in the lower half of the cornea. Thank you.